Good evening, ladies and gentlemen. Welcome to the KSOS Online Journal Club, episode 11. Now, we all know amblyopia is the most common cause of monoocular visual impairment. And we also know that a significant number of children are affected by it, something to the tune of 1 to 5%. And many of the treating ophthalmologists are frustrated by the gold standard treatment that is available for amblyopia, which is the occlusion therapy. And this issue of frustration is because of non-compliance. And this non-compliance can occur because of large number of psychosocial or non-psychosocial reasons. So if we have methods which talk of better compliance, they are always welcome in the management of amblyopia. So tonight, for discussion, we have a study, an eye tracking based dichoptic home treatment for amblyopia, a multi-center randomized clinical trial. And this month, for this episode, we have two dynamic young Turks, Dr. Divya Kishan, who is the Assistant Professor of Ophthalmology at Government Medical College, Kollam, and Dr. Gargi Satish, Additional Professor at Government Medical College, Kottayam, who will pick the brains of two veterans of amblyopia management, Dr. Laila Mohan of Compressed Hospital and Dr. Elizabeth Joseph of Little Flower Hospital, Andamali. But before we begin, we have the president of KSOS himself, Dr. Sai Kumar, with us. I'm very grateful that he has consented to speak a few words for the Journal Club. Dr. Sai Kumar, welcome to the Journal Club.
Thank you, Smita. I know that it's a wonderful program that has been going on for the past 1 year. This is the 11th in the series.
Sai, you're not very clear.
Yeah, is this the 11th in the series of?
This is the, yes,
yeah,
this is the 11th episode.
Yeah, so, the topic has been chosen. And more importantly, you've chosen the two most, important people in the ophthalmology in the state, two veterans who have gone through all the treatment modalities in amblyopia therapy. And I'm sure Dr. Divya and Dr. Gargi are going to analyze this article thread by thread, give us some excellent take-home points. And I have actually asked a lot of the juniors who have in my hospital, and as well as those who may come across and tell them that it's probably one of the most vibrant journal clubs that is going on in this part of the country. It's a very structured program, very organized one, very scientific one. And I congratulate Dr. Smita for taking the lead and doing this program. And I'm sure all of you watching on YouTube, either live or later in YouTube, will definitely be benefited by this program. I wish this program all the best, and we'll go on into the scientific session. Thank you, Smita. Thank you, madams, and Dr. Divya and Dr. Gargi.
Thank you, sir.
Thank you very much, Dr. Sai. Thank you very much. Now let us begin our journal club, and I request Dr. Divya Kishan to present the salient features of the article along with any other relevant material. Dr. Divya.
Good evening, madam.
Good evening.
Am I audible?
Yes, you are audible.
Good evening, everybody. First of all, let me thank Smita madam for giving me this opportunity to present in this 11th Journal Club of KSOS. Today, we would be discussing an article which speaks on a novel modality for the treatment of amblyopia. An eye tracking based dichoptic home treatment for amblyopia, a multi-center randomized clinical trial by Tamara Vyagnansky-Jeffrey et al., which was published in the journal Ophthalmology in October 2022. So amblyopia, as you know, is a unilateral or bilateral decrease in visual functions, which is caused by form vision deprivation and or abnormal binocular interaction that cannot be explained by the disorder of the ocular media or visual pathway itself. So abnormal visual experiences during early childhood, which could be either visual deprivation, strabismus, anisometropia, they can cause electrophysiological and anatomical abnormalities in the striate cortex and lateral geniculate body. Hubel and Wiesel's Nobel Prize winning study in 1981 gives us solid evidence for this. So what is the current state of management of amblyopia? It is based on a series of randomized controlled trials which were conducted by the PEDIC group, that is a Pediatric Eye Disease Investigators Group, which is called as a amblyopia treatment studies. So what does amblyopia treatment studies tell us? It tells us that for the first time presentation of anisometropic amblyopia in a child, spectacle correction alone can be the first stage of management. The ATS-5 or the amblyopia treatment study 5, that is the eyeglass phase, which studied 84 patients, 3 to 7 years for over a period of 30 weeks, found out that amblyopia actually improved more than 2 lines with just optical correction, and it even resolved in about 27% of the patients. Now, what is the second modality? After glasses, if it does not improve, then you can go in for the patching procedure. And what is the duration of patching that is required? And that was taught to us by the amblyopia treatment study 2A and 2B. In 2A, they studied the treatment time that is required for severe amblyopia. They compared 6 hours versus full-time daily occlusion for severe amblyopia in 3 to 7 years, and they found that 6 hours of patching is equally effective as full-time patching. And in amblyopia treatment study 2B, they compared 2 hours versus 6 hours of patching for moderate amblyopia in 3 to 7 years age group children for over 4 months, and they identified that 2 hours patching is equally effective as 6 hours patching. What about penalization? Can it be used as a first line of management? In amblyopia treatment study 1, they compared atropine and patching treatments for moderate amblyopia in 3 to 7 year age groups for a period of 6 months. And it was found that although improvement was initially faster in the patching group, but after 6 months, the difference was insignificant, so that you can use penalization with atropine also. What is the dose of atropine and duration of atropine to be used? In amblyopia treatment study 4, they compared daily atropine versus weekend atropine for moderate amblyopia, and it was found that both of them give a similar improvement. So it is feasible to restrict it to twice weekly dosage rather than daily use. But these old modalities of treatment were associated with certain limitations. First of all, it was poor adherence, then residual amblyopia, recurrence of amblyopia, adverse psychological effects, and as age increases, there is a decreased success rate. So there has been a paradigm shift in the concept of management of amblyopia in the last decade, with more emphasis on binocular treatment of amblyopia. The two modalities that have been used are the perceptual learning, wherein practicing certain visual tasks lead to improvement of visual performance. We have the Revital Vision, which is a non-invasive software-based therapy, and it helps in facilitating the neural connections of the cortical level. They basically use what are called the Gabor patches, and they are the target for visual training, and they have characteristics that match the receptive field properties of neurons in the primary visual cortex. What about dichoptic therapy? In this, you use both eyes together in order to target a reduction of interocular suppression. It can be done in 3 ways. Either you can reduce the contrast to the non-amblyopic eye, that is called the anti-suppression therapy, or you can blur the images to the non-amblyopic eye, that is called balanced binocular viewing, or you can even have an interactive binocular treatment wherein you present different parts of the visual scene to each eye as the patient watches a video or plays a game that requires binocular summation. So these are some examples of dichoptic games which were actually included in the amblyopia treatment studies. The falling blocks game in amblyopia treatment study 18 and the dig rush game in amblyopia treatment study 20. So let us see what were the outcomes of these. In amblyopia treatment study 18, they studied the 5 to 12 years as well as 13 to 17 year age groups. They compared falling blocks design versus part-time patching in these age group patients. But unfortunately, they found that there was no improvement with binocular gameplay, and that was not as good as patching. And it was thought that this is because the game is repetitive and a little boring to the children. So they developed another game, a dig rush, in which a randomized trial comparing binocular game dig rush versus continued glasses was done in amblyopia treatment study 20. But here still, they found that some benefit for younger children after 4 weeks of treatment, but the benefit was not present at 8 weeks. So the American Academy of Ophthalmology in the Ophthalmic Technology Assessment reviewed all this in the binocular treatment of amblyopia, a report by the American Academy of Ophthalmology. It actually reviewed all the published literature assessing the efficacy of binocular therapy that has been published. So in these studies also, they finally came to the conclusion that no consistent evidence is there to support the use of binocular therapy over standard treatments. And they emphasize that one potential difficulty in obtaining a positive result may be the lack of engaging games in the larger studies. For example, in this Big Rush game, which was there, the amblyopia treatment study, the adherence was poor, with only 22% of the participants performing greater than 75% of the prescribed treatment based on automatic recording of the gameplay duration. So the adherence is really poor, even less than that of patching. So it is in this context that our study comes into the importance. An eye tracking based dioptic home treatment for amblyopia, a multi-center randomized clinical trial. The aim of the study is to compare the effectiveness and safety of a novel binocular eye tracking based home treatment that is called KureSight to patching. It is a prospective, multi-center, randomized, masked, controlled, non-inferiority pivotal trial, which was conducted from August 2020 to February 2022, and it was conducted at 6 academic and community sites in Israel. Patients were recruited prospectively from the outpatient clinics of the participating centers. So what is KureSight? It is basically a software that uses eye tracking data to blur the central vision area of the visual stimuli that is presented to the non-amblyopic eye, and it encourages the brain to use the sharp, high-resolution information from the amblyopic eye's center of vision. So the components of the KureSight is, it has got a computer with 11.6-inch monitor used for stimulus presentation. There's an eye tracker that allows continuous tracking of each eye's gaze position. You need to use anaglyph glasses, blue over the amblyopic eye and red over the dominant eye. And there is also a proprietary software that uses eye tracking data to blur the central visual area of stimuli presented to the non-amblyopic eye to encourage the brain to use the information from the amblyopic eye's center of vision. What is the treatment task that the patient has to do? The treatment task consists of passively watching streamed video content presented by the system according to the child's personal preference from the web links approved by the parents. So that itself improves the adherence. The treatment algorithm, as we have already said, blurs the central vision of the non-amblyopic eye in real time using continuous gaze tracking. The diameter and magnitude of the blur are adjusted automatically during treatment according to the visual acuity of each eye, as measured at periodic follow-up visits at the clinic and registered on the KureSight cloud portal. The inclusion criteria: age 4 to less than 9 years, amblyopia associated with small angle strabismus and isometropia or both, untreated and previously treated, meeting one of the following conditions. Strabismic amblyopia, the presence of heterotropia upon examination at distance or near fixation, must be no more than 5% diopters by simultaneous prism cover test, or even a documented history of strabismus that is no longer present can be taken. For an isometropic amblyopia, a greater or more than 1 difference between the eyes in spherical equivalent, or more than 1.5 difference in astigmatism between the corresponding meridians of the two eyes is taken. Visual acuity, best corrected visual acuity of the amblyoptic eye of 2032 to 2000 inclusive, best corrected visual acuity of the fellow eye meeting the following criteria. If 4 years of age, it is 20 by 40 or better. If 5 years of age or older, 20 by 32. With an interocular difference of more than 2 lochmar lines. Those excluded included high refractive errors, myopia greater than -6, skin reaction to patches, developmental delay, low adherence to amblyopia, subjects who wouldn't wear the spectacles, history of light-induced seizures, RGP use, and any condition that prevented them from watching a monitor for 90 minutes, or a deviation that is more than 10% diopters. A total of 103 children aged 4 to 9 years with an isometropic small angle strabismus or mixed mechanism amblyopia were identified. They were enrolled at 6 clinical sites and randomized to 1:1 either KureSight treatment or patching. Each participant was assigned randomly to either the binocular treatment group or control patching group using a permuted block design stratified by site with 1:1 allocation ratio. Randomization was conducted by the principal investigator or study coordinator at each site using the secure electronic data capture web-based allocation software. Allocation concealment was achieved by keeping the randomization sequences hidden. Examiners who performed the primary outcome measurements were masked to the treatment group's assignments at the follow-up visits. So 106 patients consented. Of this, 103 were randomized and eligible. Of these, finally, 49 were included in the patch group and 43 included in the cure site group. The demographic and baseline characteristics of the participants were basically almost matched between the treatment groups and the control groups. And the binocular treatment group, what the patient had to do was to watch cure site for 90 minutes per day, 5 days a week for 16 weeks, that is accounting to about 120 hours of treatment. Whereas in the patching group, it was 2 hours of patching, 7 days a week, accounting for 224 hours. The primary outcome measured was improvement in the amblyopic eye distant visual acuity from the baseline at 16 weeks. The secondary outcomes were stereo acuity, binocular visual acuity, and treatment adherence rates. Analysis by one sample Wilcoxon test within each group was done. Safety outcomes, frequency and severity of the study-related adverse effects were also taken into account. The assessments were performed at 4, 8, 12, and 16 weeks. Masked examiners performed distant visual acuity and stereo acuity testing. Monocular and binocular visual acuity testing was performed using the CTS software. Stereo acuity was by using the RANDOT preschool stereo acuity test at near at 0.4 meters. Ocular alignment by using the simultaneous prism cover test and prism alternate cover test. Adherence was monitored in the binocular treatment group by analyzing the treatment logs of screen gaze as recorded by the eye tracker. For the patching group, it was the Guardian's manual self-reported logs. Patient treatment satisfaction was assessed using a questionnaire. So what were the results? The first was visual acuity improvement at 16 weeks. It was found that binocular treatment group visual acuity at 16 weeks was found to be not inferior to the patching group improvement. Stereo acuity improvement, there was no significant difference between improvements in the two groups for stereo acuity. What about binocular visual acuity improvement? There was no significant difference between the improvements in the two groups for binocular visual acuity. But in adherence to the therapy, it was found that significantly higher adherence in binocular treatment group was present, that's amounting to about 95%, whereas in the patching group, it was just 83%. No serious adverse effects were found throughout the study. So the amblyopic distant visual acuity, you can see at 16 weeks has improved. The stereo acuity is better, and more than 2 lines improvement was seen in more number of patients in the binocular treatment group. So the conclusions of the study is that binocular treatment was well tolerated and non-inferior to patching in amblyopic children 4 to less than 9 years of age. High adherence may provide an alternative treatment option for amblyopia. This PRSI device was an investigational device when the study was performed, and it received Food and Drug Administration clearance based on the recommendations of the study in September 2022. Thank you.
Thank you, Dr. Divya. You have built up an excellent background about amblyopia management. And then you have succinctly summarized the study. That was very nice. Now I request Dr. Gargi to give us an idea about the critical appraisal of this article and also a small bit about the statistical analysis. Dr. Gargi.
Yes, madam. Shall I share my screen?
Yes, please go ahead. Yes. Full screen, please.
Is it seen, madam?
Yeah, it is seen. Make it full screen, please.
I have made it full screen actually.
No, it has not become full screen here.
Then I will stop and again start
Yeah.
it.
Yeah.
Has it become full screen, madam?
No.
For me, it is full screen.
Is it?
Yes. Let me try once more. It's okay, isn't it?
It's not becoming full screen, but
Even now it is not full screen, madam.
no.
For me, it is what else to do?
No, I think you can go ahead like this if we can't help.
Okay. Okay, madam. So thank you so much, Smita madam, Sai sir, and KSOS for inviting me to be a part of this journal club. And it's indeed a pleasure to be in a panel with Laila madam and Elizabeth madam. Good evening to one and all. So let me go to the, what you said, usually people say the boring aspect of a journal, but yet the most important part of it, especially to any of the PG students or anybody watching this, any article or a research publication cannot be taken just like that at face value. You have to have a critical approach to it, and you have to look into the statistical analysis also. And the post PGs of the present day, they have to go take the BCBR exam. So probably they will be well versed with the statistical analysis part. Now going into the very important part of the of any article will be the selection of the topic and title, and it is definitely a very interesting and a relevant topic. Whether it is innovative, dichoptic treatment has actually been around for quite some time, but this is the innovative part. Divya has already told it. The innovative part that has been mentioned even in the intro, that they are able to quantify the amount of suppression and adjust the stimulus blur given to the dominant eye. And that is the innovative part of this device. And the next thing, which was not I highlighted earlier on, and I had to read a little bit before understanding it, is that the child can choose the material, viewing material as per his or her interests. So usual such devices are all giving repetitive and boring contents. Here, the child can, the software people just need to be updated, and the parent should give a guideline as to what all the child can watch, and anything of interest can be shown. And the child can use the anaglyph glasses and view that. So that will definitely increase better adherence to therapy. Next, the introduction part is very short, specific, well constructed. And the need for the study, the knowledge gap, these are all the basic things which has to be mentioned in any introduction to any research article, and that has been well dealt. The limitation of the present treatment modalities all have been very well mentioned with the references also. Then they have brought in a specific introduction to dichoptic therapy and a very elaborate introduction to CureSight device. They have mentioned that there were lack of too many RCTs to compare the dichoptic to patching. Lots of RCTs are there to compare patching alone, but the dichoptic to patching comparison was less. A few of the same authors had a single arm pilot study done, and that has also been mentioned. And a pilot study definitely boosts the value of any RCT. So that is also an important point. Now coming to the study objective, that has been very well clearly stated. The main objective is to compare the effectiveness and safety of this CureSight to patching. And as Divya has mentioned, it's not an observational study. We are doing an interventional study. The design of a study is very important. The prospective, done at multiple centers. It is an RCT, a randomized control trial. The randomization sequence of 1:1. It's a non-inferiority trial, which I will come to. And the evaluator who is doing the final outcome measurement is masked. So it is the design is very well explained. Now, methodology also very detailed, all aspects of materials and methods, the ethical permissions, consent, everything is clearly explained in that article. And inclusion-exclusion criteria are quite elaborate, given as a separate table. Each outcome measure has been very painstakingly explained, and how the participants have been recruited, how they have been followed up. The CureSight system totally explained in.
Dr. Gargi, are you moving your slides?
Yes.
Can you all see that the slides are moving, or is it just? I don't think the slides are moving.
No, the slides are not moving.
Okay.
Think
From the beginning, it's not been
From the
moving.
beginning, yes, it is just at the title slide.
Then, madam, shall I just exit and rejoin or something?
I think that is better. I think it's not moving.
I think you will have to do that.
I will exit and rejoin.
Okay.
Okay, madam, am I visible?
Yes, Clarky, you're visible.
Let me share again. Is it seen?
It is seen, but it is not full screen. Will you do me a favor? Can you send me your presentation?
I have sent it to Divya actually. Divya, can you just share then?
Okay, madam, let me try. 1 second, please.
For that, you will have to stop screen sharing.
Okay, okay, fine.
Madam, are you able to see the screen now?
Yes,
Yes.
yes.
Yeah.
Okay.
Yes.
Yes, yes.
Okay. Yeah, I think I will restart from where I have stopped.
Yeah, yeah.
Yeah, so you can go on. Yes, I have told all that. Yes, go on. No, just before that.
Okay.
Before that. Previous slide. Previous slide. Yes, yes. Enough, enough.
Okay.
Yes, thank you. Okay, so sorry for all that. I don't know what happened. Anyway, so the methodology again, I have already mentioned, very elaborately given. Next slide, please, Divya. Next slide. Yes, this also I have told. They have very meticulously explained the exact treatment procedure, follow-up visits. Divya has already mentioned. Next slide. Okay, the outcome measurements very elaborately mentioned, and they've taken the standard tools used in the ATS orthopedic studies. The adherence of treatment, they have mentioned that it is slightly different. that in the cure site device group, the adherence to treatment could be measured objectively because they could directly get the treatment logs from the computers. Whereas in case of the patching group, they have mentioned that it is the guardian's self-reported manual and it's a subjective measurement. Then after achieving around 90% original sample size, they did an interim analysis and which was monitored by a data monitoring committee. So such a committee and all is very important for any RCT validity. And they recommended that it is going on nicely and that you can stop at the original size, sample size of 90. One glitch I thought was that there were around 6 or 7 dropouts. The details about those dropouts and reason for dropouts has not been clearly mentioned. The next slide, please. So again, Divya has mentioned the very well-defined main outcome measures. They have put it as primary and secondary. So primary is an improvement in the it is the improvement in the amblyopic eye distance visual acuity from baseline and at 16 weeks. And then they have compared the improvement between the two groups. And so what is they have put any experimental study, you need a null hypothesis. So the null hypothesis here is that there is no difference in the improvement in the visual acuity between the two groups. That means the cure site is as equal as patching in the effect. Next slide, please. And how have they analyzed it? So what tool? The tool they have used is ANCOVA, or analysis of covariance, and the SAS is the statistical software used. So this ANCOVA is a very good tool when you have lots of covariates affecting our outcome measures. So here the covariates could be a baseline amblyopic visual acuities. For example, if the baseline acuity itself was quite good, so the improvement, it will look like a more of an improvement. Similarly, age. Suppose more of the younger age group were there, it will look like they have improved better. Or sight, there could be difference in the evaluation at different centers. So such covariates, if there are plenty, and you have 2 samples or more, one of the best analytical tools is ANCOVA, and that is what they have done. And how they have already, a priori, they have stated that this null hypothesis will be rejected if the mean difference in the improvement. So it is the mean they are taking in the difference in the improvement at 16 weeks was greater than the fixed non-inferiority margin of 0.1 logmar. So that means at 16 weeks, if the cure site group improvement and the other improvement, the difference is more than this logmar, the null hypothesis will be rejected. Next slide, please. Next slide. So when you come to the result, they have measured the mean. It is because of the covariates, they have adjusted it, and that the mean is called the least square means. And Divya has already mentioned it as 0.26 and 0.23 logmar in both the groups. And the difference between the group is 0.034. So that is well within the non-inferiority margin with which they mentioned as 0.1. So the difference between the two groups, the improvement difference is within this prior stated non-inferiority margin. So the null hypothesis stands true, which indicates that the cure site is as good as or not inferior to, equivalent to our patching method. So that is the meaning of non-inferiority. The next one. Next slide, please. Then the secondary, next slide. Secondary outcomes have already been mentioned. These were the outcomes looked into. Next slide. So secondary outcome, Divya has already mentioned. They have these are the statistical values they have taken. In some of them, they have taken median, some mean. Whatever it is, stereo acuity, binocular acuity, there was no statistical difference, but the adherence rate definitely showed a statistically significant better adherence in the binocular group. Safety outcome also, no significantly mentionable hazard. Next one. So they have fulfilled all their stated outcome measures. And Divya has again stated, just like ANCOVA, this is another very good statistical analytical tool, Wilcoxon test, which is basically used for qualitative data. So you can see it is an adherence and all that. Like, so the more of qualitative things. So that is why Wilcoxon has been chosen here. Next one. Now, randomization is the main hallmark of any RCT. Here it is 1:1 ratio. And that is done by a web-based computer software, and the allocation has been concealed. So nobody knows. So this patient is going to which group, nobody knows. The randomization sequence has been hidden. And the evaluator or the examiner performing the outcome has also been masked. So it is a well-constructed RCT. Next one. The discussion, again, they have discussed it well with the comparable studies, especially for the patching group. Lots of studies have been mentioned. Some important differences with regards to their study, they have mentioned as most of the studies bring out a significant effect of age. That means younger age, more improvement, or a prior amblyopia therapy, lesser improvement. But in this study, they have not found any effect of these. So that is one difference they have noted. And another they have noted is that they have told is that they chose an interocular difference of just 2 lines or 2 logmar for diagnosing amblyopia. Whereas usually in other RCTs in the ATA studies, it was 3 logmar. So that is one difference with regards to their study. But they have analyzed in their analysis, they have analyzed for a difference of 3 logmar and found the same effect. Next slide. With regard to the references, there are lots of references. In fact, a little too many because the standard is around 20 to 25. And they have mentioned a little bit of older ones also. Other than that, all references are there in all the sections needed. Next one, please. Limitations they have mentioned is a very important thing which every article should mention. They have taken only an isometropic amblyopia, and the dose, exact dosing and how rapidly it improves and all, they have not documented. The durability, how long this improvement will last, because it was over in 16 weeks. Similarly, I already mentioned that the patching group treatment adherence was subjectively given by the parents. So usually parents overestimate the child's adherence to patching. So that part is not clear. Then again, the non-inferiority margin is actually very conservative. They have put it as just 1 line, whereas we need to narrow it down to 0.05 or 0.075 for a good result actually. So they have mentioned these as limitations. The next one. And they have also mentioned a knowledge gap for future studies on the same subject. They have mentioned that you need a longer duration to know the effects and the durability. And you have to know whether it is useful for other forms of amblyopia for the older age, etc. So that is again very well mentioned by them. Next slide. And finally, there's lots of statistical analysis they have done. Just to mention, especially to the PGs, that sample size calculation is a very important part of any study. So for that, the important measurements required are, one is the power, the next is the significance and the confidence level. So they have started all that. I don't think I need to tell you what the power of a test is. What is the significant power of a test indicates that a null hypothesis will be rejected if it is false. And a significance is otherwise called as an alpha error. And that indicates that if the hypothesis is true, it is getting rejected. So we always hear confidence level, confidence interval, or confidence level is actually the complement of significance. So if there is a 5% significance, it is actually indicating a 95% confidence level. So these values are stated a priori. They are stated in the beginning itself. Then we need a population-based estimation of what we want to measure. So they have assumed it is 0, that the difference between the 2 groups will be 0 with a standard deviation of 0.16 logmar. So all these values are needed for us to calculate a sample size. So they have done that. Next slide. And they have stated the non-inferiority margin. I have already mentioned non-inferiority trials are usually taken for showing a new treatment is not worse than the current active treatment. And we have to mention the non-inferiority margin before itself. Next one, please. Next one, please. So again, they initially calculated it as 90. Again, you have to adjust for certain confounding factors and errors like dropouts. So 114 was reached. But then after their interim analysis, they went back to 90. So finally, they closed it at 95. So all these have been very nicely specified in their analysis part. So that is all. Sorry for the technical glitches, but you have to go in detail. Then only you can understand whether it is a good study design, whether it has been ethically conducted, whether the results are statistically sound, and the limitations have been mentioned. So all in all, I think it is definitely a very good article. Thank you so much.
Thank you, Dr. Gandhi. Thank you very much for your critical comments. And you have brought clarity to such complex statistical derivations. So I think that is very appreciable. And now I think both you and Dr. Divya, you're going to have a discussion with two stalwarts, Dr. Laila Madam and Dr. Elizabeth Madam. So please go ahead with the discussion.
Yes. Because of the technical problem, we are a little late, I think. Let me start shall I start, Divya? Laila Madam?
Yes, madam.
Yes.
Laila Madam. So since this article is about binocular therapy and dioptics, please share whether you have any actual experience or even otherwise your knowledge about such binocular vision therapy and how much is available to us in our practical pediatric ophthalmology clinics.
Okay. Thank you, Dr. Smita, for that giving us the opportunity to have a discussion on a very controversial topic. Actually, age-old gold standard patching has been still being followed in our fast life. I don't know how far it is possible with the parents working, mothers working, they live with the caretaker, maybe grandparent, and how, as Dr. Divya has already pointed out, how much adherence is possible for a patching regimen is very, very difficult to assess. Often parents say, okay, let me try again. When we say, okay, there is an alternative, always it is there. So binocular vision as binocular stimulation of both eyes simultaneously in various forms like saturation, concentration changes, contrast sensitivity changes, and all these methods have been tried since long time, more than a decade now, but no confirmative results have been found. Of course, this article had been, as pointed out already, the basis on which FDA has approved this KSOS as a method of binocular stimulation. So we have in our hospital Binox, which has more or less the same principle, but it depends upon the saturation difference between the two images which are presented to the patient, and is also monitored, completely monitored. So adherence levels are almost, you can say, more than 99%, because it is completely monitored by the from a remote controller is there, who will see that you are doing the proper thing and guide you if you are not doing it properly. The image shown to the non-amblyopic eye, the saturation levels are changed as and when the vision and the amblyopia improves. So that is what is done in Binox. The images are shown with the by anaglyphic glasses as red and blue, but and as and when the improvement occurs, there are some sort of falling blocks which the speed of which and the size of which can be changed as they go on for the during the assessment. So what we do in our hospital, the period of treatment is 30 days, or sometimes it can be extended to 40 days, 5 days a week and 40 minutes. But we don't wait till then. Every 10 days, we assess whether the visual acuity has improved or the stereo acuity also. So we don't have a very big number as yet, because the inclusion criteria is very rigid, because anisometropic amblyopia is the main category which whom we advise. And quite often we all know, as strabismologists or pediatric ophthalmologists, the patients come at about 18 to 20 years during the recruitment time, when they are rejected from recruitment. And then there is a very subtle amblyopia, but I really feel sometimes surprised to find that they've been rejected. Very small amblyopia, mild amblyopia. So then before they go for the second recruit, they want to do something about it. So this is what we have taken up as a challenge. I don't know how far it is going to work, but we have seen some improvement of stereo acuity. And of course, in older children, we give a questionnaire as to how they perform in their skill tasks, not just studies. So in that way, we can know whether this is which cannot be always assessed. The performance and the binocularity which help them in their routine work in the school, shooting, some sport activities are definitely difficult to assess by our routine visual acuity assessment, vernier acuity. All these, they don't show the binocular assessment. And I do believe that just patching and leaving them alone is not enough. I think binocular stimulation should be added to our, maybe it is an additional adjunct to patching. In the older children also, we can try this. And so we do this. To say dogmatically whether it works, this works for an amblyopia treatment, I am not yet convinced myself. But
you combine it with patching, or along with patching, this therapy also.
Usually we advise this after they have reached a plateau, or they have been patching for a very long time, and then they have either given up, or we know that they are not going to improve any further. That's when we add this. So most of them have had a course of patching, and then we start, but not simultaneously. It's just the binocs treatment.
Elizabeth, Madam, experience.
Madam, orthoptic, we are recently hearing a lot about orthoptic.
Okay. Orthoptic. Okay.
So what is your say on that?
Yeah. First of all, I would like to put on record my thanks to Dr. Smita for inviting me here. And I like to congratulate both Dr. Gagi and Divya for presenting an excellent method of presentation of the journal, and Dr. Laila for the inputs. Anyway, I am asked to talk about Orthoptech. You know, Orthoptech is a device by one of us. Dr. Santhan Gopal has come forward with this, and so this is an exclusively Indian thing. The principle is quite different. It is also a dichoptic method of stimulation in amblyopia, but the principle is entirely different from other dichoptic methods. He thinks that since the retinal ganglion cells are of two types, the parvocellular and the magnocellular, the magnocellular or the P cells are concerned with the peripheral vision, and the magnocellular M cells are for peripheral vision and P cells are for central vision. And in amblyopia, the central vision by fovea is affected. So if we stimulate the magnocellular ganglion cells by stimulating at the periphery, probably by downstream or stimulation of the fovea will catch up. That's the principle. And we have to give an exercise. It's not a home treatment. It is an institution treatment. Series of lights are shown, and every 1 hour, every day, 1 hour training has to be done. And it has to be repeated several times and for a 6 months period. And I have not used that, but I have talked to several of my friends who are using this. Even yesterday, I phoned up my friends who are using this, and they say that it is good. And articles have come in Indian Journal of Ophthalmology and JAPOS also. And they say that it is good, but it is not anything very superior to patching, but the patching is monotonous. It produces psychological problems. Compliance is poor. This is more fast. That's what people say. But the test of the time is still there. We have to wait and watch about orthoptic.
Yes, yes. Especially just giving binocular without patching, we are still wary about doing.
This can be combined. Probably during this exercise, for some time, both eyes are open. Most of the time, the amblyopic eye is only open, the other is closed, like that. Again, this also may be working something similar to patching. During patching also, the retinal periphery also is stimulated, no? So this is something related to patching only.
Okay. So, Laila madam, going to the basics, amblyopia in your clinical practice, how often do you encounter children with amblyopia, and what types of amblyopia are? Anisometropic must be the commonest, but still, what about the other forms and the general prevalence which you encounter?
In a pediatric clinic, actually not just ophthalmic, in a pediatric clinic, about 25 to 30% of the patients who come there, they present with amblyopia of the various forms. Of course, stimulus deprivation is also there, included in all these, but the main is anisometropic, and then are combined strabismic and anisometropic, partially accommodative. All these forms are very, very common, and partially accommodative hypermetropic. Anisometropy is the commonest, not the myopic ones. And strabismic and anisometropic combined one, almost equal to anisometropic, very, very commonly seen. But of course, after doing cataract surgery or traumatic cataract, traumatic corneal opacity, all these also produce some amount of amblyopia. Of course, there is an organic pathology, but we have to initiate amblyopia management as soon as they are treated. That gives a good result. That's my experience. So, yes.
For what is your indication for starting penalization as the first?
In fact,
line of
lot
treatment
of
for
customization.
Do you usually do?
Is it to me? Yes.
I was asking to Elizabeth, madam.
Okay, please.
So I have to talk about penalization as a first line of treatment. No, that's what you want.
What are the indications where you give it as
as a first line?
Yes.
First line, if the amblyopia is only moderate, not severe amblyopia, moderate amblyopia in which you think that the child may not wear patch, but the child may not be compliant with the patch, penalization is good. I usually give penalization towards the end of patching. When the patching is tapered, vision has improved to about 612. Vision was bad, maybe 5/60 or 3/60. That has improved to 612 or so. And then to continue, I use penalize. That's what I usually do. First line, probably if it is a moderate amblyopia, when patching patient may not be compliant. And these days, as Dr. Laila was saying, children are with grandparents, parents are abroad. In that case, grandparents may not find it easy to do patching. In that case, penalization is easier. You put this atropine drop in the dominant eye, the good eye.
Weekly, madam, weekly.
See, Dr. Divya had right now shown the PEDEX study in which they showed that weekly atropine and everyday atropine gives the same result. So I also resort to only weekly atropine. But if the eyes are so black, very dark, pigmented eyes, very dark, people with the pigmented eyes, people say that the pupillary dilatation and cycloplegia is less in weekly atropine. So in such cases, I give twice a week. That's all. Atropine 1% ointment once a week or twice a week, the most, in a very dark pigmented eyes. That's
side effects you encounter in these cases.
Yeah, side effects in the since the pupil is dilated, patients will have photophobia. Photophobia will be there. Pupils are dilated, and defective near vision. The studies will be affected. Whereas in patching, we are giving only part-time, means 2 hours. In moderate amblyopia, you're giving only part-time patching. So the rest of the time, the child can study well. Here, the good eye also is dilated, so reading will be difficult. Photophobia is there. Some people complain of headache. Like such small problems are there.
Laila madam. So traditionally itself, once you start treatment for amblyopia, you usually tell to increase or when you're doing patching, to do more of near activities. Those studies have shown that both distant and near activities are nearly the same, but still near activities are always. So what do you advise, madam? What all activities do you usually advise?
Yes, usually when they come, especially with amblyopia, we must know whether it is moderate or severe. Actually, we cannot ask them to start reading with the eyes patched when it is a severe form of amblyopia. Worse than 660, it is very difficult for the child to do his routine work. But if he can do his homework and read his class notes and do drawing, even computer, sometimes the parents come and ask me, please ask him to stop looking at the smartphone or computer. So I tell them, when you patch, you can give the video game or whatever he is doing, only unless he is patching, don't give. And even watching TV also sometimes, but it doesn't help that much as when he is reading, because we know to what extent he can see when he is asked to do his homework with the eyes patched. But not always it's possible. But the next time they come, quite often after another 6 weeks when they come, the mother volunteers to say that now he can do his homework with the eyes patched. So we have to, it's a very much customized thing. We cannot generalize this to everybody.
In particular games or anything in the mobile for any?
Whichever they actually, all these are to stimulate, are done to stimulate the neuronal activity. So whichever he is comfortable with, but like falling Tetris, all these things are available in the smartphone. So hand-eye coordination is also improved when they do some video gaming. So that in that way, their skill also improves. So I ask them to do some, quite often they do a lot of football, or a lot of things are there now. I don't specifically say this particular game, but whatever he is doing, let him do with his eyes patched. That's all.
Elizabeth, madam, in some
I asked them 1 hour, at least 1 hour of near work in a moderate amblyopia, and in a severe amblyopia, at least 2 hours.
Elizabeth, madam, in some cases, in anisometropic amblyopia in children, there are studies where eczema laser is done. So what is your say on that?
Say, I'm a pediatric ophthalmologist, but I'm doing laser LASIK surgery also. So I have done LASIK in such cases. What I feel is that in high anisometropia, if you want to correct the refractive error, you have to give contact lens.
Yes.
You have to give contact lens. And some of the children are not compliant with the contact lens. There is contact lens irritation. They don't wear the contact lens. Then there is no other way than to do an LASIK, excimer laser surgery. In high hypermetropia, see, hypermetropia stabilizes by the age of 10 or 12 years. So you can safely do hypermetropic LASIK by 10 or 12 years, and that will be stable for the rest of the life. Whereas in myopia, if you do early, there is chance that myopia will progress, and after some time residual power will come. That we know. But even then, to correct the anisometropia, LASIK has got a big role, provided if the patient is not wearing contact lens. The patients are wearing contact lens, it's better to push and reach up to maybe 18 years or so. In partially accommodative esotropia, also hypermetropic LASIK is very good. Partially accommodative.
So how old, from how old do you do that, madam? How young?
So the problem with LASIK is that they have to lie quietly, look at the fixation target. So the child has to be cooperative. The child is not cooperative, it's impossible to do. The laser beam will become eccentric and problems will occur. So the child has to be cooperative and has to lie down with the looking at the fixation target. So that will take about 10 years or so at least, maybe 8 years. That's the main thing. That if you do it as early as 8 or 10 years, you can expect some refractive error to come after some time. But if you're doing a hypermetropic LASIK at 12 years, probably he's corrected for the rest of the life.
Okay. Laila, madam. So what about in the older child or in an adult? The amblyopia has been, as you said, that is a tragedy, that it gets unilateral anisometropia or an anisometropic amblyopia. It gets detected only when they go for a job recruitment. So in such a case, when it has not been detected before, it's an older child, above 15, above 18. What's your experience? How much, what do you do?
Yeah. Definitely, the first line of management will be an optical correction. Refractive correction is the first line. So, of course, as has been proven of late, that even older children or adults respond if you give optical correction. I've seen some of them responding even late into 20 after past 25 years. So we have to give correction, optical correction, and bring them back. But sometimes they want everything to be done in a short time. That's how they come to us. So we bring them back after giving glasses for a month. They come back and see whether they are comfortable with glass and see whether they have improved. Astigmatism, meridional amblyopia is very common that way. See whether they have improved or improving. And then, of course, even in older children, I ask them to watch TV or do some activities with patches on for 1 or 2 hours. But sometimes it is not possible. For 2 hours, they may not get, if it is a severe form of amblyopia in an older child, because they have class, they have to dedicate their in their study. So sometimes it is not possible, but at least 2 hours, if it is possible, I ask them to patch also. And in the older, as you said, those who are going for recruitment, we advise this is a possibility, binocular treatment, but the recruiting for binocular treatment is very rigid. So they should not have a tropia of more than 5 prisms. Otherwise, we do with prisms on. We give prism glasses and then do the binocular treatment. Okay. So if the patient is willing, actually we have, in order that a patient who has been patching for a very long time, when we say that it costs about 15 to 16,000 for a binocular treatment. Cost is also a factor, and we have no guarantee that they will get into the recruitment list. So sometimes it is difficult. So we have how we go about it now is that we divide, and we do see them every 10 days, so that they are not asked to do complete. Initially, we had started like that. We used to complete 1 month and then bring them back and see how they are doing. But now every 10 days, we see how they are progressing, and even payment is done in installments. So to make it easier for them, not to give, previously it was difficult to convince them actually to give the whole amount at the first instance and then go on. Sometimes they are not willing, so a lot of dropouts were there. Now we have made it more feasible for them. So that's how we do about it.
The anaglyph glasses, which they are given time slots.
We dispense the anaglyph glasses and they do it at home. After the initial session, there is a diagnostic procedure. There are 2-3 session modalities in Binocs. There is a diagnostic modality where they can check vision also in a computer. And then the phoria, tropia, everything will be checked by the digitalized mode. And if it is high, the phoria or tropia is a large one, then they advise this cannot be. So then we have to correct it first. If it is a small angle strabismus is there, then you have to correct it and then bring the person back. So we have to follow all these before. Not a large strabismic amblyopia can be put into the Binocs directly.
Okay. Elizabeth, madam, what are your experiences with pharmacological therapy for amblyopia management?
Yeah. My experience alone, if I am saying, I have given citicoline. I usually give citicoline to recurrent amblyopia. We have treated amblyopia, vision had improved, and after say 2 years they come back and say, see, one school screening test was there, and on the school screening they found to be amblyopic again. So when I look at the chart, the patient had good vision and then patient lost follow-up. Such cases I have given citicoline, and citicoline I give 200 milligram daily. It can be given up to 90 days or even up to 1 year it can be given. I have seen that some improvement, it gives some improvement. It has to be continued along with patching. And there are no side effects that I can vouch upon. These children are happy taking that. I have not noted any side effect with citicoline. And then in the literature, you can say that levodopa, carbidopa, all are there, but all are in experimental stage. It's not widely used. Citicoline can be given. How much it is effective? I have started patching and citicoline together. So probably the patching has worked, or whether the citicoline has worked, I'm not sure. But I am very confident that it has no side effect. It can be tried. It can be tried. It's a last option. Some people are so desperate. Can you do something? Can you do something? They ask. And these medicines are given by the neurologists for other purposes. So that is time tested. So I feel confident. I give it in once in a week. That's all.
I think our time is nearly up. One or two last questions, madams. What about in strabismic amblyopia, the classic doubt? What do you deal with first? Is it the squint part, or do you manage the amblyopia bit and then do squint? Laila, madam, both.
Definitely, there is no question. Amblyopia has to be attended to first. And sometimes it is very hard for them for us to convince them that this has to be corrected before strabismus. We take up for strabismus. It is not easy, but definitely once you see some improvement, that vision is improving. After convincing them that they have to continue patching, then we can take them up for, need not wait till the amblyopia is improving and improve to the same level as the vision has become equal. So we can take them up, but it is to be definitely counseling is an important factor in all these cases. Counsel that even after patching surgery is not a shortcut for patching or glasses. All these things we have to convince them before we go in for surgical procedure. So after that, follow-up is very, very important because surgery, the younger children below 3 years, they respond very well to amblyopia management. So we can take them up before 1 year, of course, they alternate in a month. If you give patching, they start alternating in a month. So we can take them up because that is how we know when they are freely alternating, we know vision is equal. So then we can take them up. But in the older child, when we know there is some severe amblyopia, which responds slowly, then we have to wait till they start improving. When the amblyopia improves, then we can take them up and continue patching or continue the amblyopia treatment.
Anything to add, Elizabeth, madam?
I'm also of the same opinion as Dr. Laila. What I do is I first give patching and make them aware that this child has got defective vision and patching has to be done. At least minimum of 1 or 2 months of patching. And once it has started alternating, or at least if I am sure that this child is going to wear patch, parents will do patch, then I take up for surgery. So, an early surgery has got an advantage because during patching, if in patching, you are covering one eye only for few hours. Rest of the time, eye is strabismic, and again the binocular interaction, abnormal interaction is going on. So it's better to correct early. I don't delay much. I must 2 months time, 2 or 3 months time I delay to start on occlusion and to convince the parents, counsel and all. And then I do surgery. When the eyes are straight, the chance of improvement of amblyopia also improves. So that is one thing I have to add.
Okay. Smita, madam.
Actually, I think we'll have to, this discussion could have gone for a bit more, but I think we'll have to wind up because of the constraints of time. So to summarize, I feel that you have covered very well most of the modalities, including the use of excimer laser and the prism glasses and the binocular treatment varieties. That was all very well covered. And thank you, Laila madam and Elizabeth madam, for sharing your practical experiences. These actually make our journal club much more vibrant. And thank you, Gayatri and Dr. Divya, for asking the right questions. Really appreciate it. Thank you, ma'am. Thank you, ma'am.
Thank you. Both of you have done a wonderful job, Dr. Gagi and Dr. Divya. So it was really
asking you questions, madam.